The important topic which we are going to discuss today is about the liver resection. Now, for the liver resection, it is very, very much important to know a little bit about the surface anatomy, plus also to know about the segmental distribution of the liver, then the proper anatomical planes, so that you should be doing the dissection in avascular planes. But before that, starting discussing about the liver resection, the principles, the mobilization of the liver and dissection of the liver, this is important to know why you are going to resect the liver and what are the planes, or what are the extent of the resection of the liver. So it can be traumatic reason, a liver trauma which is massively bleeding, and it's important. It becomes very important to resect the liver. Secondly, it can be because of the smaller non-anatomical lesions. And then for that, you can go for lobectomy, or you can go for segmentectomy, or you can go for right hemitectomy, or you go for the left hepatectomy. Plus, you can also go for liver resection in case of the follicular nodular hyperplasia, or you can also go for liver resections in cases of hepatocellular carcinoma. So just moving to today's topic, first of all, you need to know a little bit about the anatomy. So we know that if we talk about the surface anatomy of the liver, so we know that there's the upper margin of the liver and there's a lower margin of the liver. So usually the upper margin of the liver can extend to the second costal cartilage. So we start palpating the liver from the second costal cartilage, and we know that the inferior margin of the liver or the lower margin of the liver is just involving the extend is just below. It can extend to below the subcostal margin, or it can extend below 12th rib. So the overall, if we talk about the size of the liver, so it is usually ranging between 10 to 12 centimeter. But sometimes when you're palpating the liver and there's a hepatomegaly, the liver actually may extend just below the costal margin. So that's why it's important that you should know about the surface anatomy of the liver. So if you are planning for a liver resection, there's some kind of prerequisites for that. You should have a proper ultrasound, or you should have a proper CT scan if you're doing for the elective resection in case of the adenoma, or you are treating the hepatocellular carcinoma, and you should be well known about the lesions which are being present. Then second most important thing is to involve the anesthesia team to be very helpful in that, because they have to keep the central venous pressure low. Because if we all know that liver has got massively profuse blood supply, so whenever you are dealing with this compartment, it can bleed profusely. So if the CVP is greater than 6, or it's somewhere greater than 10, so there is a more tendency to bleed. So that's why it's important to keep the CVP, just the central venous pressure, should be below 6, so that the active or the profuse bleeding of the liver should be compromised. The general principle still is important, because you need to make a proper incision to get the proper exposure of the liver. And then second most important thing is like mobilization of the liver. So because the liver is connected to different structures by the help of the ligament, so the ligament division is also important. Then you have to get the exposure to the inferior vena cava, and ultimately you have to separate the hepatic veins that are entering into the IVC. And then obviously you have to go for the parenchymal resection. And there's some important maneuvers and some aspirators, surgical aspirators, which can be used for that. So starting from the incision, because you need a proper exposure. So initially, in the previous eras, usually thoracoabdominal incisions were used. So this is the thoracoabdominal incision, which is extending in the midline, and it is starting from the second costal margin, and it's bringing down to the Z4 process, and still in the midline and the umbilicus, extending to the umbilical region. So this particular type of incision is called thoracoabdominal incision. So in case of the thoracoabdominal incision, you can have a good exposure of the stomach, the omentum, the lesser omentum, plus the margin of the liver, the superior and the inferior. So but now most importantly, the incisions which are being used today are the transverse subcostal incision. And because in such kind of, the incision, the retraction is very, very much important. You have to retract the costal margin and the diaphragm, and so that's why retraction of the liver is also important. Plus, this is the starting point for the subcostal transverse incision. Okay, so you're just starting below the subcostal region, and you are extending this incision. If you could appreciate, these are basically the generalized incision. Okay, so this is the incision which is starting from this is the incision given for thoracotomy, and these are the midline incisions which are used mostly for the laparotomy, and these are the incisions at the level of T4, which is the nipple area of the nipple, and these are the incisions which are involving this right paramedian incision, and this is the subcostal incision, and the transverse incision. So you go for the right hypotransverse incision, which is starting from the right hypochondrium, extending to the midline, and you can extend it to the Z5 process for a good proper exposure. Or other than that, there's another incision, which is you started from the right hypochondrium, you extend it to the Z5 process, and then you extend it to the left quadrant as well, left hypochondrium as well, so that the left lobe of the liver should be properly, adequately exposed. So always remember, either use thoracoabdominal incisions, they are not in use anymore. So most importantly, we use two incisions, which are the right hypotransverse incision, or you go for the subcostal incision, which is extending to the Z5 process in the midline and extending to the left hypochondrium as well. So right hypotransverse incision and the subcostal incision, which is starting from the right hypochondrium and extending to the Z4 process, and then you're bringing it down all the way and exposing the left hypochondrium. So if you're starting the exposure or you're starting the incision from the right hypochondrium, you are actually gaining the exposure to the right lobe of the liver. And the midline, obviously, this is again the extension of the right lobe of the liver. And for the proper adequate exposure, you need to expose the left lobe of the liver as well. So what you do is you extend this incision to the left hypochondrium as well. So always remember two most important incision, right hypocostal incision, which needs actually a lot of retraction, and the subcostal incision starting from the right hypochondrium, extending to the midline up to the xiphoid process, and extending more laterally on the left side to the left hypochondrium. So these incisions are important when you are planning a liver resection. The second most important thing when you're done with making the incision, and you have already made the incision, you excise you start incising the skin, the subcutaneous tissue, and then ultimately you open up you go deeply So yeah, you cut the anterior rectus sheath, then there's the anterior rectus sheath is probably enclosed, it's enclosing the rectus muscle. So you cut the rectus muscle and you go inside, you reach the posterior rectus sheath, and then you go deep down and you open the peritoneum. So when you open the peritoneum, you are just right lobe of the liver is just in front of you, and then you start. Important thing is the mobilization of the liver. Now, this is important that how you are going to mobilize the liver. So, four important things which are important in the mobilization is the different kind of the ligaments which are connecting the liver to different structures. Okay, so we actually know that there is a falciform ligament, and the falciform ligament is actually responsible for the division of the right and the left lobe of the liver. And plus, falciform ligament is extending and it is attaching to the liver to the wall. So you divide the falciform ligament, and when you divide the falciform ligament, then comes the right and the left triangular ligaments, and then you have to first you divide the falciform ligament and you reach the part of the liver which is the right and the left lobe of the liver, a technical demarcation between the right and the left lobe of the liver. After the division of the the falciform ligament up till to the point where you can see the anterosuperior surface of the IVC, where the portal vein is entering into the IVC. So you can see that this is the IVC, and there are different portal veins which are entering into the inferior vena cava. So you need to expose this area, because you ultimately need to go to the posterior superior surface of the liver, in which behind the liver there is the inferior vena cava. Then the second important thing is like you need to divide the right triangular ligament and you need to divide the left triangular ligament. So you divide the left triangular ligament, which is connecting the left lobe of the liver to the stomach, and then you have the right triangular ligament, and you have to get exposure to the diaphragm. You need to retract the right costal margin, and you need to retract the diaphragm above so that you get the right lobe of the liver sufficiently exposed. Then you have to divide, or you have to open the lesser sac. Okay, so you get into the lesser sac, you get into the lesser omentum, and then you get into the liver bed, or you get into the hilum of the liver. So the hilum of the liver is important. Why this is important? Because the common bile duct, the porta hepatis, or you can say the portal vein, the common bile duct, the hepatic artery, and the portal vein, they're entering into the liver through the hilum of the liver, and you need to get hold of this. When outside the liver, this is the liver parenchyma, right? And these are the structures which need to enter into the liver. So what happens is like the three important structures: the portal vein, the common bile duct, and the hepatic artery. So actually the common hepatic artery divides into right and the left hepatic artery when they're after entering into the hilum of the liver. And then you have the portal vein as well. So there are some tributaries which are coming from the right and the left border or the lobe of the liver, and they join together and they make the portal vein, right? And then you have the common bile duct, which are again coming from the right and the hepatic ducts, and they combine together to make the common bile duct. So we know that the right lobe has got its own vascular structures, and the left lobe of the liver has got its own vascular structures. And the triad is the same. It can be right hepatic duct combining with the left and making the common bile duct. So in the right, or the right lobe of the liver, you have got the right hepatic artery, you have got the tributary of the portal vein, and you have got the right hepatic duct as well. So on the other side, if you talk about the left lobe of the liver, you have got the left hepatic artery, you have got the portal vein, a tributary of the portal vein, and you have got the left hepatic duct as well. Okay. So these actually they are common when they're outside the hilum, but once they enter the hilum, after they entering the hilum, they divide into the right and the left branches, and they pass to the different structures or the different segments, and they actually divide these into three anatomical divisions, and then coming to the eighth segment. So if you could appreciate in this diagram that this is the inferior, this is the superior posterior surface of the liver, and just behind the superior posterior surface of the liver you have got the inferior vena cava, and portal vein is entering into the inferior vena cava. And then this is the left lobe of the liver, and this is the right lobe of the liver, right? So starting from here, you have got different segments. This is segment 1, which is posteriorly. This is segment 2 laterally, segment 3 laterally. And then coming medially, you have the segment 4, which is divided into segment 4A and the segment 4B. Then coming into the right side, you have the segment 5, which is inferiorly located. You have the segment 6, which is inferiorly but laterally. Then you have the segment 7, which is laterally but superiorly. And then you have the segment 8, which is located just above the segment 5. So why this is important to actually divide? Because, in between these segments, there are some important planes which are called as the avascular planes. And when you go into the avascular planes, the likelihood of a troublesome bleeding that can be prevented. That's why it's important to mobilize the liver and to go into the avascular planes of the liver. So what you do is first you get a proper adequate exposure, then you have to mobilize the liver, and if you're mobilizing the liver, you have to cut or you have to divide the falciform ligament, you have to divide the right triangular ligament, you have to divide the left triangular ligament, and then you have to open the lesser sac. And when you open the lesser sac, you are actually reaching the bed of the liver, or you're reaching the hilum of the liver. And then comes another important part, which is about the dissection, and you go into the avascular planes. And the second most important thing is like the division of the parenchyma as well. So this is again the same picture, which is probably mentioning more of the vena cava. So this is the suprahepatic part of the vena cava, and these are the hepatic veins. Okay, so these hepatic veins are actually entering into these hepatic veins actually enter into the superior part of the vena cava, or suprahepatic part of the vena cava. Then you have this portal vein as well, and then you have the aorta on the other side, and just below that you have the duodenum as well. So why this is important, you just need to remember, you don't have to go into much of the details, but you need to keep this thing in your mind that you have to mobilize the liver. For the mobilization, divide the falciform ligament, divide the right triangular ligament, divide the left triangular ligament, and open the lesser sac and get into the hilum of the liver. Then the second most important thing in this scenario is the ligation. Okay, so this is important to ligate all the smaller vessels and all the larger vessels which are coming into your focus. You have to ligate the portal vein, you have to ligate the hepatic veins, you have to ligate the hepatic artery, you have to ligate the cystic artery, and you have to ligate the cystic duct as well. So actually what you do, you when you are into the liver bed, you're on the inferior surface of the liver, then you have to go for the cholecystectomy as well. So what you do is you get into the Cowlitz triangle. So if you remember the boundaries of the Cowlitz triangle, it's the superior margin of the liver, and the right hepatic artery, and then the cystic duct. And in between the cystic duct and the right hepatic artery, there is the right hepatic duct. The boundaries of the Cowlitz triangle are the superior surface of the liver, and then you have the cystic duct, and most medially you have the right hepatic artery, and in between you have the cystic artery, right? So you have to ligate the cystic duct, and you have to ligate the cystic artery, and then you have to remove the gallbladder from the bed of the liver, right? When you're done with that, you are done with the ligation of the vessels, you're done with the ligation of the veins, and you're done with the cholecystectomy. Then after You're sure about the hemostasis because it's important. The liver bleeds massively, right? So this is important. You secure the hemostasis when you are, doing dissection. Coagulation, diathermy is somehow very, very much important. Plus, you need the anesthesiologist to help you keeping the CVP pressures low, because if the CVP pressure would be greater than 6, there is a chance of massive bleeding coming from the liver. And if the CVP pressures are below 6, it's safe to proceed. Plus, how you could actually keep the CVP pressure low, by restricting the fluids and by putting the patient on a drip of triglyceride nitrates. So that will obviously bring down the CVP pressures, because they are the dilators, and we know that the venodilators, mostly the nitrates are specifically known for the venodilation effect. So when they dilate, they will bring about the CVP pressure low. That's how you can keep the CVP pressures low. Okay, so when you're done with the mobilization of the liver, the second thing is the dissection of the liver. And always remember, you have to go into the avascular planes. You need to identify the segments of the liver. And when you are entering into the liver parenchyma, if you could appreciate here, this was the suprahepatic part of the liver. This was the infrahepatic part of the. This was the suprahepatic part of the vena cava, and this is the infrahepatic part of the vena cava as well. And you can see the different portal and the hepatic and the portal vein, which is entering into the liver. When you're done with the ligating these structures, because you need to ligate the portal vein, you need to ligate separately. Okay, just this is the hilum of the liver. Okay, so when you are at the hilum of the liver, what you need to do is you need to resect or you need to ligate these vessels. And you need to ligate the hepatic, common hepatic, the portal vein, and the common bile duct as well, or common hepatic duct, because you're high above the liver, so there would be no common bile duct. But sometimes when you are already done with the ligation of the cystic and you separately ligate the hepatic, then obviously there would be no influx to the common bile duct. So you ligate these structures, the larger structures, the larger veins and the smaller veins, you just simply ligate them. And then what you do is you put a sling on that. And after that, you take a hold of the liver parenchyma. Like this is the part of the liver which is probably the demarcation between the right and the left lobe. For instance, you're doing the right hepatectomy or you're doing the left hepatectomy, then you need to get into the hilum of the liver and you need to ligate the right hepatic or the left hepatic, depending upon what you're doing with that patient, or what is the side of the operation or what is the extent of the operation. Then what you do is you ligate those important vascular structures and you put a sling, and if you could appreciate, this is the demarcation line between the right and the left lobe of the liver. And this is a thing, you just go beneath that and probably expose that, and you have to take hold of that sling. Okay, so that's how you can actually divide and you can do the dissection. These are again the important structures which are entering into the liver, right? So this is the inferior vena cava, the suprahepatic part, and then this is the suprahepatic inferior part. And these are the important structures which are actually entering into the hilum, and they are then dividing. Okay, so they're giving branches to the right lobe separately, and they're giving branches to the left lobe separately. So same happens here, that this is actually the hepatic, this is the hepatic duct. Okay, and the hepatic, this is probably the gallbladder, and this hepatic duct is combining with the cystic duct and making the common bile duct. So what happens is, like, this hepatic duct is coming from the right, right is a right hepatic and from left is left. So you need to ligate them separately when you are planning to do the right or left hepatectomy. Again, the same things, the suprahepatic part of the vena cava. This is portal vein, which is behind the hepatic duct. This is the inferior vena cava, and this is actually only when you have exposed the CBD, which is a common bile duct, and you're done exploring the common bile duct and you have ligated. Then what you do, you can put the T-tube for the drainage, whatever the residual drainage which is coming to that part, and then you have this a common bile duct, and you ligate the other structures, the hepatic and the cystic, and you remove them, and then you place a T-tube into the common bile duct if necessary. And you can see the celiac artery, and this is the donor hepatic artery, which is coming from the celiac artery. Now, another important thing is like when you dealing or you're doing dissection of the liver, dissection of the parenchyma, there can be massive troublesome bleeding. Okay, so what you need to do, first of all, keep the CVP pressures low, or you do the Pringles maneuver. This is important, the Pringle maneuver. So what you do is you put a clamp, avascular or atraumatic clamp, just over the foramen of Winslow or in the lesser sac. So actually, the foramen of Winslow contains the portal vein and the portal vein and the hepatic artery, common hepatic artery. So when you do the Pringles maneuvers, you do it by the help of your fingers. You simply press that part in the lesser mentum in the foramen of Winslow, or you put a non-crushing clamp over that. And this is, or it's a kind of applying a tourniquet to that part. So when you have clamped that, the vascular supply, the proximal vascular supply, or you can get a proximal control of the vasculature. And now this is important for how long you can do this. Almost the tourniquet or the clamp you have applied to that part can be safely placed for 90 minutes. But another thing which becomes important is like if you're already dealing with a cirrhotic liver or you're dealing with some lesions or pathologies, then obviously there would be some kind of failure or the fulminative hepatic failure. So obviously we don't want because of the vascular compromise. So what you do is another technique which is being used instead of placing a clamp for a whole about 60 minutes or 90 minutes. What you do is you place the clamp for 20 minutes, then you remove it for 5 minutes, and you keep on repeating this so that at least some vascular supply should be continued. So you keep the clamp for 20 minutes, then off it for 5 minutes, then keep it for 20 minutes, then remove it for 5 minutes. That's how you actually you can say like it's an intermittent occlusion or intermittent compromise. So somehow especially if the liver is already cirrhotic or there's some kind of a metastatic lesion in the liver, that becomes important because you need not to do a complete avascular bed created for the liver. Now coming to the parenchyma, division of the parenchyma, which is the hemihepatectomy. It can be either right hepatectomy or it can be the left hepatectomy. So this is important. Like the main thing was mobilization, the exposure, the mobilization, and then obviously controlling the vascular part as well, getting the proximal vasculature control, and then mobilization, and then obviously reaching the hilum of the liver and identifying the vessels and then ligating them one by one. And then you go to the division of the liver. Okay, so the division or resection of the liver can be initially in the previous stages when not much of the surgical intervention were there to help. Usually a finger method was used, and the parenchyma was being crushed by the help of your fingers. But now today we have some important surgical aspirators, and we use that, especially the Cavalton surgical aspirator that is particularly used. And what the hepatic cells, they are vaporized, and then you can easily divide the liver parenchyma. So if you could appreciate here, it's post hepatectomy, so probably this is the left lobe of the liver, and the right lobe of the liver has already been resected, and the coagulation is being also maintained. And after getting the exposure, mobilizing the liver, and getting a good proximal vasculature control and securing the hemostasis, you use a surgical aspirator, which is the Cavalton surgical aspirator, and you aspirate the hepatocytes, the liver cells, and the rest of the parenchyma is divided easily. Now, there can be segmental and the local resections, and these can be in the anatomical planes, or this can be in the non-anatomical planes. So the smaller lesions, which are located in a non-anatomical plane, this simple wedge resection can be a word that can be used for that. But other than that, you have some segmental and the local resections. So either you do the segmentectomy, I have shown you in the previous couple of few pictures, you actually divide the right and the left lobe into different segments, and 4 segments on the left lobe and the 4 segments on the right lobe. So you can either remove one segment because maybe the metastatic lesion or adenoma may be located to that particular segment, or so you do the segmental or the local resection. And a local resection can be simple. If it's a non-anatomical plane, it can be simple wedge resection. And if you do maybe a lobectomy, the whole of the lobe of the liver is being removed, that is also part of the local resection. And in some cases, in extensive diseases of the liver, you have to go for a complete liver resection, and then obviously the transplantation would be the option. There can be another technique which can be used as a laparoscopic liver resection. The principle still remains the same, and all the laparoscopic resections are using, the creating an hemoperitoneum and then dividing, and you just go into that, a further exposure, and again ligating the important structures, dividing the ligaments, ligating the important structures, and you do the liver resection. Now, how would you control the blood loss and transfusion? Now, this becomes very, very much important, because if you are dissecting in normal, some kind of avascular planes, so it's least likely that you would actually lead the liver to bleed massively, right? So an important thing is this, that if you are a general surgeon and you are working in a primitive setup, or you're working somewhere in the periphery, so you just have to if the liver is massively bleeding, or if the patient has come to you, reported to you after a traumatic avulsion of the liver, so what you do is actually you just pack the liver, okay? So you just pack the liver and give a good ICU support and refer the patient to a specialized surgical center. And but important thing is this: we know that liver bleeds massively because it has got a good vascular supply. But if you are in a setup, in a specialist surgical setup, or you are in a setup in which you need to save the life of the patient, then you have to go keeping better surgical anatomy in view, better segmental anatomy, not doing the dissection in the vascular plane, avoiding, keeping CVP pressures below low, better selection of the patient, and it's ideal if you keep the pressure somewhere between 5 to 8. But that's important. Some books give a cutoff value of 10, and some books give a cutoff value of 6. But keeping the CV pressure below 6 is important. And for that, you can restrict the fluids, or you can actually put the patient on nitrates because they're good venodilators. Then antifibrinolytic drugs, they can be very helpful, like apritonin. So you can be using them per-operatively or pre-operatively. And then you have some kind of topical fibrin glue or fibrin impregnated collagen fleece. So if there's a massive bleeding and you are unable to identify the artery which is bleeding, right? So what you do is you just put the fibrin glue over the site of the bleeding, or the fibrin impregnated collagen fleece can be used, or you do the Pringles maneuver. And like Pringles maneuver, you place the non-crushing clamps over the site which is actively bleeding, because the foramen of Winslow, which is in the lesser sac, holds the portal vein and the common hepatic artery. So that's how you can use. Another important thing is, like, you can use the organ beam coagulators, and these organ beam coagulators or diathermies can actually help you dealing with good hemostasis, and then obviously the Pringle maneuvers. Now, there are some important things which are also, they're not very much helpful, but still, if you can delay the surgery, so especially in case of the tumors, the hepatocellular carcinoma or the metastatic deposits which are present in the liver, you can go for the ablations. And ablations can be like radiofrequency ablations. And in radiofrequency ablations, this becomes important because you need to set those ablations on specific frequency, and usually they ablate the lesion wherever they are present. But the complication with the use of the radiofrequency ablation is the recurrence, okay? And sometimes these frequency ablation can also damage the normal liver parenchyma. So this is important because ultimately the liver has to be resected. So if you are working in a specialist center and you have good expertise available with you, then go for the liver resection instead of going to the radiofrequency ablation, because the complication is obviously recurrent. So this was about the liver resection. So always keep in mind adequate exposure, and prerequisite is like do the CT or MRI and isolate the lesions wherever they are present, plan accordingly. And then mobilization of the liver is by dividing the different ligaments, starting from the falciform ligament, right triangle ligament, left triangle ligament, and then obviously opening the lesser sac and getting into the hilum of the liver, getting control of all the vasculatures, and plus keeping the CVP pressures low. And then reaching the posterior superior surface of suprahepatic part of the vena cava. And then obviously, because the hepatic vein is actually entering into the inferior vena cava suprahepatic part, and then you have to do the parenchymal dissection by the help of surgical aspirators. And then at the end, maybe if you could do some kind of the CBD exploration, or you ligate the CBD as well, then a T-tube can be placed. But usually in case of the liver section, there's no indication for the placement of the T-tube, because you already ligate the proximal supply, which is coming into the common bile duct. Then at the end, it's important to follow the avascular planes for the dissection to control the bleeding. And if bleeding still happens, then you can go for a placement of the collagen glue, or you can use the antifibrinolytic drugs, or you can actually do the Pringle maneuver, or organ beam coagulators can be used. that becomes a principle of the liver resection. And you usually do the liver resection in case of traumatic avulsions to the liver or traumatic lacerations of the liver, or you do that these resections when there is a kind of a adenoma, or there's a kind of local lesion, which maybe some in case of larger hemangiomas. And sometimes you need to do the liver resection in case of the hepatocellular carcinoma, depending upon which segment of the liver is being involved. And then sometimes you can use the radiofrequency ablations as well. But the complication with those radiofrequency ablations is recurrence, and ultimately you have to go for the liver resection. So this was about the general principles of the liver resection. Now we will be talking a little bit about the benign tumors of the liver in today's lecture, and then in the next lecture we'll be discussing in detail about the hepatocellular carcinoma, which is a metastatic tumor of the liver, a malignant potential tumor. So talking about the benign liver tumors, the first thing which needs to be discussed is about the hemangiomas. So hemangiomas are the benign tumors which are actually coming from the blood vessels, and they're the vascular tumors, okay? So usually these hemangiomas are a kind of the incidental finding. Maybe a CT scan was ordered for some other pathology, maybe for the cirrhosis of the liver, or CT abdomen for some other kind of the disease or presentation, and there was incidentally a hemangioma was being reported. And usually these hemangiomas are smaller lesions, and for the small lesions you do not need to do anything, okay? So if you could appreciate, this is a CT scan of the abdomen, and the cut section is involving is showing you the part of the liver. So this is the liver, and you can see that in the left lobe of the liver there is a non-homogeneous lesion which is being present, or you can say the hypodense hypoechoic lesion which is present in the left lobe of the liver. So probably this is a hemangioma, which are the incidental finding, and the patient is not symptomatic. If the patient is not symptomatic, then you don't have to do anything. You need there is no surgical intervention needed for that. But if the patient is symptomatic, or still the hemangioma is larger, then you can go for the surgical operations like the liver resection, or depending upon the hepatectomy, or the local resection. And the complication with these hemangiomas, like the larger hemangiomas, they have a tendency to rupture, and then when they rupture, they bleed very badly and very profusely. And for that, what you need to do is you need to open the patient immediately, and you need to build up the patient, and you need to give the transfusions as much as possible. So for the smaller lesions, hemangioma is a kind of incidental finding, and no surgical intervention is required. For the larger hemangiomas, liver resection is indicated, and for the ruptured hemangiomas, exploratory laparotomy immediately with the blood transfusions and buildup of the patient is recommended. And there's another benign liver tumor which is called hepatic adenomas. And let me tell you, these are vascular benign tumors, and they are very well defined. They are irregular, and they're mostly, if we talk about the age group, so they're ranging between 25 to 40 years, and is more common in the women, and especially the women which are using the oral contraceptive pills. We do not actually know the mechanism behind all this, especially what role oral contraceptive pills are usually, they are playing in the development of the hepatic adenomas, but they have incidence for the development of the hepatic adenomas. So remember, women using oral contraceptive pills in age ranging from 25 to 40 years, they have a tendency to develop the hepatic adenomas. And the important thing is like they have the potential to convert into the malignant hepatocellular carcinomas. So that's why it's important to resect these tumors, especially those tumors which are greater than 5 centimeter in size. It is clinically indicated and it is practically indicated to resect these tumor. So this is again the CT, which is actually showing you this is the part of the spleen and this is the liver, and you can appreciate that just the lower part of the right lobe of the liver is being occupied by the hepatic adenoma. And if the tumor is less than 5 centimeter, then surgical excision is not required. But if the tumor is greater than 5 centimeter, so there is a likelihood of development or into a full-blown malignant cancer. So that becomes important to resect these hepatic adenomas, especially women ranging between 25 and 40 years and on the use of oral contraceptive pills. They should be screened routinely for these hepatic adenomas. Then talking about the benign liver tumor, there's another entity which is called as focal nodular hyperplasia. So what does that mean? That means that there is a enlargement or there's a hyperplasia of normal functioning liver with the part of the fibrous trauma as well. So in case of the focal nodular hyperplasia, they also have the tendency for development into a malignant potential cancer, which is obviously adenocarcinoma or the hepatocellular carcinoma. So for that, this focal nodular hypoplasias, they can be picked up easily on ultrasonography. So the screening should be done in case of these patients. And if patient is symptomatic, then these the part of the liver which is undergoing hypoplasia, they should be resected, which is involving the local resection. So these are the three important benign conditions which we usually encounter when we are dealing with the benign tumors of the liver. So for today's lecture, we have been talking about the indications for the liver resection. We have been talking about we have been discussing different principles and different stages which are involving the part of the liver resection. And then at the end, we also discuss about different benign tumors which are involving the liver. In the next lecture, we'll be talking about the malignant tumors, especially the hepatocellular carcinoma, their pathophysiology as well, and then especially the colorectal cancers, which are have a very much high incidence to get metastasis into the liver. So that's all for today. Thank you for watching sqadia.com with Dr. Sanaka.